Thanks, Chris. So the concern we have with these patients is that, certainly we've treated these patients. The disease goes it's as quiet as it possibly can be, but we know it's always there lurking. So because they've had disease in the past, they have the virus present in their sensory ganglia, and any type of traumatic event, specifically surgery, may cause really a twofold problem. Number one, there's an issue that maybe it will reactivate and cause active live virus in the perioperative period, or number two, that you reactivate this immune response, which really can cause as much equal havoc in the eye as far as scarring and inflammation. In addition to that, to just the surgery insult in and of itself, we almost always all of us use topical steroids in the perioperative period, and this again is additionally suppressing the anterior segment function of the eye, and so you may have to fight these two components. I think the problem in these patients is that we really don't have a lot of literature to go on and lean on, and so actually, I think when I submitted my slides even a week ago, there's really no even retrospective or prospective studies looking specifically at cataract surgery in people who have had herpes zoster or simplex. And then just this week, it was actually e-published ahead of print in JRCS, was a study out of Kellogg, which looked at 24 patients. And I think just as we're talking about with treating any condition, just warning these patients that you're not a typical cataract patient. You have another disease in the eye that we may need to treat and may have potential effects even after the surgery. They think this is kind of behind them and it's been treated, but we all know that's not the case. And this study is actually pretty concerning to read from my standpoint. It was a tertiary care center, so probably they're treating patients who had more severe zoster disease, but you can see that initially they did see an improvement in vision at 1 month and then at 1 year, but over that time there was a slow decrease, actually, that there was no statistically significant improvement in these 24 patients from preoperative to postoperative vision. And they really had some significant complications afterwards, where they had a lot of patients. 11 patients had recurrent keratouveitis, 3 went on to require PK because they had worsening corneal opacification, and 2 patients actually required vitrectomy because of significant uveitis. So certainly, I think they probably had more severe patients than we're seeing on our office, but I think just giving the patient the heads up that this might be a long haul and not a typical recovery after cataract surgery is very important. So how about evidence to guide our treatment? Well, really, as I already mentioned, there's no specific evidence. If we can kind of extrapolate from those who have had PKs for zoster or simplex, certainly the literature has shown in those cases that there's reduced number of recurrences and better graft survival in people who are treated with oral prophylaxis. There was a recent questionnaire that was sent to cornea specialists in England, and not a lot of consensus here really on how to treat these eyes. Majority of people certainly would wait extended period of time, 3 to 6 months of quiescent disease before going ahead with surgery. I was surprised at this, only over half would consider starting antiviral treatment, and most of those would use acyclovir. Most would not use topical antiviral treatments. It's not surprising. They're already on so many topical agents. Adding another one can be difficult. And most of them actually would not change their steroid routine regimen. So certainly I think we do this in patients who have uveitis as well, or any other condition where we know that the most stable period, if a patient can wait, the longer the better before pursuing surgery. Certainly I think at the minimum it should be 3 months before any activations, before considering operating these patients. Even those who have had simply epithelial disease or even stromal disease, we definitely want them to have stable corneal topographies, and this may be 6 months to a year until their irregular astigmatism may be normalizing. My suggestion, I think, is just to have a low threshold for prophylaxis. The risk of oral therapy is really quite low, but as we can see from the Kellogg study, the risk from a recurrence in the perioperative period is very high. So, it's a discussion you can have with your patients, but I think acyclovir, valacyclovir are some of the safest medicines that we have out there. So if it were me or my family member, I would certainly opt for prophylaxis. Exactly what dose of prophylaxis is certainly not known. I think acyclovir, because it has a longer time to reach steady state, I tend to start 3 days prior to surgery, whereas valacyclovir or famciclovir 2 days before, and doses usually BID is sufficient. As far as how long you keep patients on prophylaxis really depends on their disease, and I think close monitoring of these patients was what's going to be key. I would say probably at least a week's time would be recommended. That being said, if you're concerned because they've had activation in the past, especially while on steroids, keeping them on prophylaxis while they're on topical steroids is probably going to be best. And then those who have already been on prophylaxis, so I have a few people who have had so many recurrences when they're off any prophylaxis and have been quiet while on it, they prefer to stay on maintenance dose prophylaxis really indefinitely. And so in those patients, I get them back to their prophylactic dose, but I increase them in the perioperative period. I don't use topical prophylaxis, and I think you may have some good coverage, but you're compromising additional toxicity and cost to the patient when they're already using other topical drops. Surgical considerations, you see these patients that have scarring. The slit lamp really doesn't look like a big deal to you, but you can be quite surprised when you get to the operating room and your view under the microscope may be much worse. So, just monitor these scars carefully and consider using trypan blue if you think it's going to obscure your view at all. Especially with zoster, they can have iris atrophy and necrosis, so they may more likely have floppy irises or may not dilate as well, so you may need to use a Malyugin ring or hooks, and you also may need to take care of their synechii. Postoperatively, I was surprised that a lot of the cornea physicians in England don't consider any change to steroid regimen. I think it depends on the type of disease. Obviously, if they just had epithelial disease in the past, you wouldn't need to alter your postoperative regimen. But in those who have had recurrent keratouveitis in the past, some of these patients may even still already be on a low-dose steroid to keep them quiescent. So I think treating these patients initially pretty aggressively, especially if you're already having them on oral prophylaxis, aggressively treating them with Durezol, a stronger agent, or every 2 hours prednisolone for the first week's time until you get an idea of where they're going to land inflammatory-wise can be important. I would very, very rarely use subconjunctival or some TEDONS injections in patients who have had really fulminant uveitis in the past, and I would probably even bump up the dose of oral acyclovir or valacyclovir if you're going to consider doing this. But certainly I would be hesitant to do that, especially with trabeculitis issues we'll talk about afterwards. And you may consider tapering these patients more slowly too, just as we do when we're treating our patients in the office. Sometimes by a drop every 2 weeks, so tapering them really over a 2-month period rather than 1-month period, and then maybe even going from something like prednisolone to Lotemax and a lower dose before you're tapering them off completely. NSAID, you may need to alter that regimen as well. They're going to be more, if they have stromal or uveitic disease, they may be more susceptible to CME, so probably using an agent is important. That being said, we'll talk about next, I think one of the biggest problem is that a lot of these patients are neurotrophic, and so you're going to be dealing with ocular surface issues. So some of the generic NSAIDs, if you do use those, I would say these are the cases not to use a generic because you're going to compromise the ocular surface more than helping prevent CME. I think the biggest problem that I seem to face from these patients is really their ocular surface afterwards. And with these patients being neurotrophic, you really have to do everything to promote their surface being as stable as possible beforehand. So if they're not already plugged or considered punctal cautery, really have their surface optimized beforehand. Sometimes I would avoid using lidocaine gel because that really can beat up the cornea surface for that first postoperative day and get you behind the 8 ball. So maybe consider just intracameral agents in these patients and avoid the gel. The day of the surgery, I would consider ointment and patching them, or even just a collagen shield can be quite helpful in these cases. And then I really have a low threshold for using a Procara or amniotic membrane. Usually I wait until about 4 or 5 days so you get an idea of where the inflammation is, and you can have a pretty good view of the eye before placing this. But definitely would see these patients at the minimum a week, and if their surface is breaking down, go ahead and treat aggressively. IOP can be an issue as well. They already have, a lot of these patients have a compromised trabecular meshwork, and adding one more inflammatory response or surgical insult can make the trabeculitis worse. I do avoid prostaglandins. There's some anecdotal or published studies that show that maybe the prostaglandins reactivate the virus, so I do avoid these in the perioperative period. But even people who have normal pressures preoperatively, if you're watching them or they have any inkling of going up at all, I would treat them somewhat presumptively in the first month's time. Vaccination is something that I certainly wouldn't recommend in the perioperative period. I'm a big proponent of vaccination, but those people who have had recurrent disease that are in the category where we're really not quite sure, I think they did also did a survey of cornea surgeons in the U.S., and most people actually don't even recommend vaccination in people who've had recurrent ophthalmic disease, because there's a theoretical risk that you're stirring up that immune response as well. The risk of this is very rare, but it certainly is something, if someone's considering vaccination, I would avoid doing it anywhere close to the perioperative period. So in conclusion, these are patients that you really need to watch carefully and treat aggressively, but fortunately there's not a lot of studies that can lead us exactly to tell us what we should be doing standardized, but I would recommend having a low threshold for oral prophylaxis in these patients and just monitoring their topical medicines carefully. Thanks.